Welcome to the Silicon Slopes Live. My name is Clint Betts. We're here with Dr. Kristin Francis from the University of Utah Health. Dr. Francis, thanks so much for joining us.
Yeah, thank you for having me.
We really appreciate you taking the time. Could you tell us and those watching either live or later on here a little bit about your role at the University of Utah?
Yes, absolutely. So I am a child and adolescent psychiatrist at the University Neuropsychiatric Institute, which is the freestanding psychiatric hospital for the university. I'm an assistant professor there in general at the University of Utah. So I lecture to residents, medical students, in addition to seeing inpatients who come into the hospital for a myriad of reasons. We also have an outpatient clinic, which is also called Uni Outpatient Clinic. So the University Neuropsychiatric Institute is made up of two different parts, both an outpatient portion and an inpatient portion. I'm trained as an adult psychiatrist as well, but I subspecialized in child and adolescent. And so in the hospital, when children are admitted or adolescents, they come to see we go to see them, and there's a team made up of a psychiatrist, a psychologist, and a social worker. And so that's what I do during the day. I'm a hospitalist.
This may seem like a very basic question, but what is the difference between a psychiatrist and a psychologist?
I'm so glad you asked. It's just a really confusing thing for most of us. So a psychologist is a PhD and they have their doctorate, but they got that by going to college and then like a 4-year graduate program and then doing some extra graduate schooling on top of that. They are licensed to practice therapy and do assessment testing, and they do a lot of really important talk therapy. A psychiatrist is a medical doctor who went to medical school, did a residency, and then started to specialize in mental health and typically prescribes medications for mental illness.
So, Dr. Francis, I'm wondering, because you specialize in adolescents and child psychology and as well as adult, as you see the state about to reopen.
Yes.
And I think, it's the 1st of May, so somewhere around there. And so that could mean a lot of parents are going to go back to work, but their children are still at home because school's not reopening. What advice do you have for parents and how to deal with not deal, but you understand what I'm saying, how to interact with their children during this time, how they can make both work and caring for their child who's supposed to be at school but can't be at school right now?
Yeah.
What advice do you have both for parents and maybe even for government officials during this time, and like certain policy they should be coming up with?
Okay, so that's a great question. I definitely want to talk about that, especially the part about what parents can do in their day-to-day life to make things go better with children, because right now we know it's a very stressful time for everybody. Right now, people should feel uncomfortable and anxious, and there's a lot of uncertainties, and that's normal, and it's okay. It's absolutely okay to feel more worried, find that your thoughts keep going back to COVID and wondering what the next steps are. It's also very normal right now for parents to be kind of stressed and tense and maybe short-tempered with their children. I would recommend in general, it's really good to set aside at least 20 minutes a day of just positive parenting time that you can have with your children, which we recommend as like a child-led preferred activity. So it's not, you coaxing them to play Scrabble with you. It's you asking them what they would like to do and then joining them in that activity and trying to not make any suggestions about how to do it differently. And we found that that's an evidence-based intervention that really seems to improve relationships with kids. And we know that the more that you improve a relationship, the more someone wants to listen to you and follow your directions and please you. So we think that's a really great place to start. I think we get a lot of questions right now about kind of what is the next right step, and no one really knows, right? There's a lot of uncertainty. And I think that is something that makes people feel more anxious, again, which can be normal during this time. And as stress levels continue to be high, you can even start to feel a little depressed. And I think that's, again, very normal. In times like this, we see a natural kind of adrenaline surge when there's a crisis. And so typically utilization of mental health resources goes down temporarily. And that's really where we're at right now. So initially, our psychiatric hospital is almost always full. Right now, we have a little bit more room, and that's the same with the outpatient setting. Typically, it takes 3 to 6 months to see a psychiatrist. And right now, we have some openings because there's different theories of why, but some of those reasons are that, again, think people kind of get this adrenaline boost, and there's some evidence that the society kind of pulls together and really helps work and support each other. And then the data starts to show that as that time period goes on, more symptoms of depression and anxiety accumulate, and there is a higher utilization again of those services. And at times, so we anticipate that things will go back to what we call normal soon in terms of being pretty busy. And we're also trying to put some supports in place for what to do with the extra depression and anxiety that we anticipate may come from this crisis.
What is a normal emotional response during this time?
Yeah, so I think a normal response is definitely one of grief almost. There was a really great article that I'll forward along from Harvard talking about the stage of grief, kind of a loss of a sense of what we're used to and an uncertainty about the future. And I think, again, that's very normal. We're also working on physical distancing, which is, we can't see the people that we love, and we can't get as much physical touch as we're used to. And we're keeping our kids from their friends. And there's just a lot of new rules. And that takes a lot of brain energy. And also it can be hard emotionally. So I think it's very normal right now to feel anxious, a little bit down, and to be kind of like, very worried about the uncertainties of the future. I also think that the physical distancing guidelines are going to continue for a while, right? That's what everyone's saying, is that we're going to be asked to continue doing this. And so it's really, really important right now that we're doing as much virtual contact as possible with the people that we normally interact with, so that we stay connected and not separate.
What are some signs or symptoms that a stress response to COVID-19 has progressed to something more clinical, like clinical depression or anxiety?
Yeah, so I'm really glad you asked that. I get asked that question all the time, and it's very normal for a person to feel depressed one day, have a low mood, you're having a bad day. When we in the mental health field talk about clinical depression, we are talking about a very specific set of criteria that when we looked at large groups of people, we found that they all had in common. And those are, over a 2-week period, a change in sleep, either sleeping too much or too little. Typically, we see what we call terminal insomnia. You can't sleep in early morning awakening. Either increase or decrease in appetite. Some people overeat, kind of more like carby foods. Some people just lose their appetite. Depressed mood almost all day, every day. Or real irritability. Men especially present more with irritability than a sense of sadness or depression. You also can get some feelings of worthlessness and hopelessness, which a lot of people find they struggle with. Like, where is this coming from? I have a great family. I have a job. I have health insurance during this time. Why am I feeling so terrible? It's kind of a disproportionate sense of guilt and worthlessness that doesn't make any sense. It's not logical. There's nothing wrong in your life that should be making you feel that way. And we find that when this depression progresses, it often leads to suicidal thoughts. And these are thoughts that often start off as passive and can turn to be more active. And so the thoughts initially can just be like, oh, I just wish I could be done feeling this way. I wish I could just go to sleep and never wake up. Or they can be a bit more active. I wish I could just, crash my car into something. Or then they could progress to something even more active, like maybe I should take pills, or maybe I should, think about a gun, or maybe I should actually do something to try to end my life. And that is a very strong warning sign of major depression. And the more those thoughts go on, the more used to them a person becomes. And that is why it is so important, as soon as you start having those thoughts, if you do, you reach out and ask for support, because we know that depression is a biologic mental health disorder that can be fixed. It can be treated. So there's no need to go through the suffering like that. Anxiety, on the other, it's hard to know which comes first, because depression also often has anxiety accompanied with it. And depression is, there's about, at any one time, there's about 7% of the population that will have depression, right? So anxiety is about double that. And they include all the anxiety disorders like OCD, panic disorder, generalized anxiety disorder. Those are like your worry warts, those situations. But anxiety is usually like a chronic sense of restlessness, unsettledness, preoccupation. We call it rumination, where your mind goes around and around and can't seem to distract itself or get off of a worst case scenario. And anxiety can lead to depression, and depression can lead to anxiety. So again, really important to recognize and get help as soon as possible.
What treatments are available for depression and anxiety?
Yeah, so that's a great question. We have a lot of treatments, and the best treatment we've found for a severe case of major depressive disorder is a combination of medication and therapy together. And there's a synergistic quality to that. When we look at studies, medication alone is helpful, and talk therapy is even slightly more helpful, but when together, that's when they really work. And so typically depression is, clinical depression is due to kind of a deficiency in one of three or all three important neurotransmitters, serotonin, norepinephrine, or dopamine. And our brain circuitry that controls how we feel about ourselves, how we sleep, how our appetite, all of that is controlled by neurons communicating with each other through these neurochemicals. And these neurochemicals are so important and valuable that our nerve cells recycle them. Every time they them out into the synapse, after they start that chain reaction, they recycle them back up into the nerve. When you're depressed, for some reason, there's a deficiency and there's not enough of that serotonin or norepinephrine or dopamine. And so we prescribe medications, typically serotonin reuptake inhibitors, or SSRIs. You've heard about them. They're like Prozac, Lexapro. And those medicines basically block the recycling cans at the end of the nerve cells, so that when your body spits out serotonin, it lasts longer and has more of a chance to kind of rejuvenate this sluggish response. And so that's typically our first step. And we would also then recommend that you meet with a therapist, which can either be a licensed clinical social worker, or it can be a psychologist, a PhD doctor, just like we talked about, who will go through evidence-based therapies that will help you be able to get skills, learn how to manage your everyday behaviors while we're waiting for the medicines to work.
What about buying a puppy? My wife and I just bought a puppy for our kids this morning. Will that help? Is that going to help us?
I think buying a puppy is always a good idea. I mean, definitely not stressful. Definitely just great. No, I think buy all the puppies. Hedgehogs. I particularly push hedgehogs.
That's a good idea. Hedgehogs. How is COVID-19 impacting patients with mental illness?
Yeah, so again, at any one time, we see kind of a steady amount of the population that suffers from depression, anxiety, schizophrenia, bipolar disorder. But then when you add a big crisis, you tend to put more stress on someone who's already vulnerable, because we know that a mental health condition is a combination of genetics and then environmental factors. So when you increase the environmental factors, it can really stress a body out. And so we're seeing the same trend with COVID that we would anticipate, an initial decrease in utilization of resources because people are kind of at home and they're adrenalized and they're trying really hard, maybe getting some extra support. They're kind of trying to fight through things. But then as the pressures continue, the chronicity is what really can trigger more of those episodes. So then we see again a resurgence of symptoms and people who need support.
President Trump recently brought up the risk of increased suicides if the economy remained shut down, and that the numbers would exceed the death toll from COVID-19. Can you comment on that?
Yeah, so that was a pretty powerful statement, and I went and I was curious about it, and I went and did some research on it. And currently, as of today, we know that COVID has unfortunately killed 60,438 people in the United States alone. In comparison, like in 2017, which is our most current suicide data, 47,000 people took their lives by suicide. About half of those were by a firearm. So already COVID has surpassed the number that we would expect of typical suicide rate. But I went and looked at times of economic crisis, and there's a really good article from 2013 by an author named Chang that's cited a lot. And they looked at the financial crisis in 2008 and also the crisis in the 1980s. And both studies found a pretty similar finding, which was in the initial part following the economic depression, the suicide rate remained the same. However, within 2 years, that suicide rate increased by about 4 to 6%. So, and they controlled for all the other variables. And so what they found was after the 2008 financial crisis, about 5,000 more people took their lives. So that went from, if it still doesn't seem to me that it would even near a number like COVID, but I don't know what resources or data he's referring to. In general, when we talk about suicide, it's a really delicate topic that I think needs to be talked about. We have seen the suicide rate consistently go up since about 2001. We've seen a rate of about 31% overall, if we look at the data from 2001 to 2017. So that goes from like 10 out of 100,000 to 14 out of 100,000. We know that males are 4 times more likely to complete suicide. We know that women are more likely to attempt suicide. Men often use firearms, and so there's been a lot of discussion about firearm protection or firearm securing firearms when you're suicidal, and we always want to be respectful of everyone's Second Amendment right. And there is evidence that if you take away access to a gun, you do reduce the risk of suicide. People used to think, well, if you take away their gun, they'll use something else, kind of a harm substitution model. But the evidence that is out there from the National Suicide Institute is very clear that when we take away, for instance, veterans' guns, they are less likely to complete suicide. And when we just take them away temporarily, no one's talking about taking away anyone's firearms permanently. It's just in a depressed and suicidal situation.
Dr. Francis, what has the University of Utah done to help with mental health during all of this?
Yeah, so we're lucky to have such great resources already. So even before this, we had a crisis hotline. Utah has a crisis hotline. We ourselves have a Safe UT app, which you can download on your phone if you're an educator, a student, or a parent of a student, and you can text someone in the time of crisis, which is super helpful. There's also what we call a warm line, which is just a line more if you need encouragement and support. It's not the same as the crisis line, which is what you call if you're acutely suicidal. We also have, currently we have more room in our outpatient clinic, if you need emergency psychiatric or psychologic services, we can get you in. We're even offering some same day appointments with psychiatry, which is really cool because, again, typically it takes about 3 to 6 months to see a psychiatrist. And the fact that right now we can get you plugged in and hooked up, it's really exciting to us. Also, if you go, there's some great links on healthcare.utah.edu/uni. And there's lots of links to like the Resiliency Center, where they have all sorts of online resources from the CDC on personal well-being, family well-being. They have some really nice, accurate data regarding what COVID-19 is and what to tell kids and how to handle it. They also have some screening tools for depression and anxiety. And I think that's really cool. So you can go on and actually just take an anonymous quiz and find out if you meet criteria for depression or anxiety.
So finally, Dr. Francis, what recommendations do you have to support personal well-being during this time?
So I definitely think, we hear it a lot, but routine, right? So anything you can do to keep yourself structured. A lot of people, may have already worked from home and so have had set a routine, but even they will find that their routine is now disruptive as their spouse is home also. And how do we manage that? Kids are home. So some type of a routine or schedule for your family, really, really important. Predictability, as much predictability as possible during these uncertain times. Then of course, exercise. And I just mean movement. It doesn't actually have to be exercise, but get outside, get sunshine, move your bones, do a dance party, do something. We want you really to think about reducing your use of alcohol or substances right now, because there's a tendency towards increase. If you look at Australia right now, they're really struggling with increased alcohol use. We want you to stay connected with friends and family virtually as much as possible. We recommend scheduling that every day. And there's lots of nice platforms out there that I'm sure your users are much more familiar with than I am. I also think it's really important to remind yourself that this is temporary and this is not permanent and this is not the way it's always going to be. And that can, again, help find some reassurance and some hope. Lastly, I think for people who are really, really struggling, I think trying to help other people, getting outside of yourself, getting outside of your head, that can be a really great opportunity to promote your own sense of well-being by giving service to others. So again, there's also some really great talk therapies out there that have specific techniques and tools that you can actually do in the moment when you're flooded by deep, intense negative feelings. There's also, for some of us who are less emotional minded and more logical minded, there's another form of therapy called CBT, which is cognitive behavioral therapy, where you look at how your thoughts impacts your behaviors and your mood. So there's also, and then there's also another therapy called ACT, that's a value-driven therapy. So there's basically like a therapy for everyone. It's not just one type, and it's not the old kind of classic therapy that I think a lot of people think about, where you lay down on the couch and you talk about, your mom. Although there is some evidence for some people that type of therapy works too. So again, therapy for everybody. There's a flavor for you.
Dr. Francis, thank you so much for coming on. I also want to acknowledge everything that the University of Utah and University of Utah Health is doing during this time. It really has been incredible. We need to have you back on. I could talk to you for hours about this.
Oh, you're great.
Sure.
Thank you. I want to say, I speak with a lot of clinicians in different states, and Utah has done an awesome job. We are prepared at the hospital. They have been practicing. They have great policies. They have been utilizing their researchers to print 3D masks from the beginning. We have a lot of hope and gratitude also towards Utah. Utah's done great.
I love to hear that. Thank you so much, Dr. Francis.
Welcome.
We'll talk to you again.
Thanks.
Have a good one.
You too. Bye-bye.